All right. So,
Dear colleagues, it's a great pleasure for me to deliver this recording speech about gliomas in the context of the sprint, i.e. training for medical imaging, knowledge translation. Perhaps let me briefly introduce myself first. I'm the director of the neurosurgical department in Leuven, which is one of the academic hospitals. Dear colleagues, it's a great pleasure for me to deliver this recording speech about gliomas in the context of the sprint, i.e. training for medical imaging, knowledge translation. Perhaps my talk today aims to provide you with an overview. Let me briefly introduce myself first. I'm the director of the neurosurgical department in Leuven, which is one of the academic hospitals. Dear colleagues, it's a great pleasure for me to deliver this recording speech about gliomas in the context of the sprint, i.e. training for medical imaging, knowledge translation. Perhaps my talk today aims to provide you with an overview. Let me briefly introduce myself first. I'm the director of the neurosurgical department in Leuven, which is one of the academic hospitals. Dear colleagues, it's a great pleasure for me to deliver this recording speech about gliomas in the context of the sprint, i.e. training for medical imaging, knowledge translation. My talk today aims to provide you with an overview. Let me briefly introduce myself first. I'm the director of the neurosurgical department in Leuven, which is one of the academic hospitals. Dear colleagues, it's a great pleasure for me to deliver this recording speech about gliomas in the context of the sprint, i.e. training for medical imaging, knowledge translation. My talk today aims message. This MRI definitely depicts a space-occupying tumor. We may observe.
Okay, sorry, I noticed that there was some challenges with the video. I'm going to start the stream again so that we can just have
Dear colleagues, it's a great pleasure for me to deliver this recording speech about gliomas in the context of the sprint, i.e. training for medical imaging, knowledge translation. Perhaps let me briefly introduce myself first. I'm the director of the neurosurgical department in Leuven, which is one of the academic hospitals of the University of Münster. I'm also appointed as an associate professor for neurosurgery at the University of Münster Medical School, as well as clinical professor for neurosurgery at the University of Nicosia Medical School. My talk today aims to provide you with an overview of the current glioma clinical management in terms of a tutorial. My first slide could simply be also the last one, since it summarizes my talk and includes a take-home message. This MRI definitely depicts a space-occupying tumor. We may observe the sylvan fissure, which is shifted cranially, and the sulci, which are not well identified. This tumor is called glioblastoma and is the most common primary malignant brain tumor. It has a poor prognosis even after a complete therapy consisting of surgery, adjuvant chemoradiotherapy, as well as application of tumor-treating fields. The degree of resection at the initial stage is critical for the cause of the disease and the patient's outcome. If we are willing to resect the process beyond the tumor borders seen in MRI as shown in this photo, then we may have the chance to see MRIs like this without any tumor recurrences, also 2 and 3 years later. The structure of my tutorial will be the following. Initially, we will refer to data concerning the epidemiology and diagnostics of gliomas. We will then elaborate on the clinical management of gliomas, in particular the current surgical management and how we could achieve our main goal, namely the maximal safe resection. After the presentation of the modern surgical management of gliomas, we will bring up the adjuvant therapies and briefly mention the current radiotherapy and chemotherapy regimens. After that, we will review some cases with low and high-grade gliomas. There's no better way to start my talk than saying that the diagnosis of a primary brain tumor does not necessarily mean also poor outcome and death for the patient. As we may observe in the statistical reports of the Brain Tumor Registry of US for the years 2015 to 2019, malignant primary tumors account only for the 28% of the tumor entities. Approximately 40% are meningiomas, 17% pituitary tumors, 8% nerve sheath tumors, and 6% other tumors like tumors of the pineal region. All these tumors show an excellent prognosis after successful surgery, which is in the majority of cases the sole therapy of choice. The next case is a typical example of a challenging benign brain tumor which requires only an appropriate surgery. Mr. C, 58 years old, comes from Scotland but works in my city in Lunen and was found in a coma with dilated and fixed pupils. The MRI showed a giant tumor of the pineal region causing hydrocephalus. After implantation of an external ventricle drainage, we proceeded with the resection. You may see the segmentation of the huge tumor marked in red. At the top right side, you may recognize the sagittal, coronal, and axial planes of the preoperative MRI, which are projected during the surgery in my microscope oculars. We have performed a supracerebellar infratentorial approach. This means we observe the tentorium at the left and at the right side, and the deep venous system in the background. As seen in these pre- and postoperative MRIs, the tumor has been completely resected and the patient has recovered well from his disease without any deficits. And again, this was the case of a benign brain tumor. However, the vast majority of gliomas demonstrate malignant features. Only 1% of the primary brain tumors are benign gliomas. Glioblastomas account for the most malignant entities, namely for 50% of all primary malignant tumors or 59% of all gliomas. Large-scale epidemiological studies in patients from multiple racial groups have demonstrated interesting patterns of racial differences in gliomas. The white race presents the highest incidence rate of about 3 to 4 new cases each year per 100,000 inhabitants. This rate is reproducible from many studies in US, UK, Australia, and Europe. Hispanic inhabitants demonstrate a lower incidence rate of 2.5 per 100,000 inhabitants, whereas the Chinese population only 1. To my best of my knowledge, no concrete data from the African population are published yet. However, the incidence of brain tumors in general in Northern Africa and Middle East has been increased at about 150% in the last 2 decades. Incidental gliomas are the exception. Patients with gliomas usually demonstrate general or focal neurological symptoms. The symptomatology depends, of course, on the localization of the tumor. Patients with low-grade gliomas usually present with seizures, whereas patients with glioblastomas more often with symptoms like aphasia or motor deficits. The final diagnosis of the entity is provided by the histological examination. However, the preoperative MRI is highly predictive of the tumor pathology. Since the current training will elaborate on neuroimaging later, I will not go into many details now. Briefly, a glioblastoma usually shows contrast enhancement of its margins and a central necrosis, whereas is surrounded by perifocal edema. The 5th edition of WHO classification of brain tumors differentiates now between grade 4 astrocytomas IDH1 mutant and grade 4 glioblastomas IDH1 wild type. In addition, it incorporated further molecular biomarkers into the diagnosis of grading, like TRT promoter mutation and EGFR amplification, allowing diagnosis of a grade 4 even in cases that appear histologically as lower grade. The known histological criteria for malignity, like high degree of cellularity and nuclear polymorphisms, remain unchanged. The prognosis of patients with glioblastomas is extremely poor. The median survival is estimated at about 8 to 9 months according to the US Brain Tumor Registry, when all patients with glioblastomas, treated or not, are considered, whereas only 15% of the patients survive more than 2 years. A slightly better outcome with an overall survival between 12 and 20 months is seen in cases after complete treatment. Beneficial prognostic factors are younger age and the better neurological situation of the patients, whereas also specific molecular background like methylated MGMT status or wild type of IDH1 is linked to a more favorable outcome. As mentioned previously, the degree of the tumor resection is critical for the outcome of the patient. The ALA study first provided robust evidence about the prognostic superiority of gross total resection compared to subtotal resections. The ALA study was a randomized, 2-armed, controlled, multicenter phase 3 study comparing fluorescence-guided resection using ALA with conventional microsurgery. Surgery under ALA facilitates tumor discrimination. More details will be given later during my talk. Patients were enrolled into the ALA study at 18 German study centers. Patients without residual tumor survived longer, 16.7 months against 11.8 months for incomplete resections. Survival advantage from complete resection remained significant also after adjustment for age and eloquent location. A more recent systematic review taking into consideration the 5th edition of WHO classification confirmed the prognostic relevance of gross total resection in patients with glioblastomas. They demonstrated a median overall survival of 20 months after gross total resection. Jackson et al. Reviewed the significance of supratotal resection, namely resection beyond contrast enhancement, and report an even more beneficial outcome compared to only gross total resection. We have several tools during the surgery to maximize the resections, namely the neuronavigation, the fluoroscopic guided surgery, the intraoperative imaging or modern intraoperative visualization techniques of a micro or exoscope, like an in vivo confocal microscopy or Raman scatter spectroscopy. I will now present you a case in order to demonstrate the role of neuronavigation and fluoroscopy during the surgery. This patient developed a glioblastoma of the left insula, a highly eloquent region. In order to protect the healthy brain parenchyma and to avoid causing an aphasia, we will choose an approach to the tumor through the Sylvian fissure. The neuronavigation will allow a more precise trepanation and a better anatomical orientation during the surgery. We know at any time where we are, where we operate, where the tumor lies, and more importantly, what to expect in deeper layers. The following video demonstrates the fluoroscopic guided surgery in this patient. During the surgery, we recognize the Sylvian fissure, which should be opened. After its partial opening, we face the insula, but we do not recognize directly any obvious tumor yet. It's time now for the fluoroscopic microsurgery. We switch the microscope modus from white light into blue light and identify the tumor, which now demonstrates a pink color and is different from the adjacent healthy tissue. In order to do that, the patient should drink 4 to 6 hours prior to surgery a specific medicine called 5-ALA. Obviously, we aim at a maximum resection only if it is safe. In order to achieve this, we need some tools for the constant monitoring of the brain function. We need also a change of our thinking. Apart from the traditional neuroanatomy, we must consider also the functional one. Traditionally, we learned about the eloquent centers of speech at the Broca and Wernicke area, of the motor and sensor pathway at the precentral and postcentral gyrus, as well as the occipital lobe as a visual processing area. However, this is rather simplifying version of neuroanatomy, which does not consider the functional association fibers between these different eloquent centers, namely the fiber bundles. These fibers should be identified and protected during the surgery, since their damage may cause severe deficits. We may recognize in this anatomic slice in cadavers the fasciculus arcuatus, which connects the speech areas of the brain like an arch. Its damage during the surgery would cause severe aphasia. Modern tools which allow a constant monitoring of brain function are the intraoperative imaging of fiber bundles, namely the tractography or DTI, the intraoperative use of electrophysiology, and the awake surgeries. This MRI look quite different without and with depiction of the fiber bundles. The right MRI provides a significant piece of information in order to choose the appropriate approach and to protect the fibers during the surgery, since we know now where they are, which leads to a better functional outcome after surgery. The neurophysiological monitoring is being routinely used during brain tumor surgery in order to prevent irreversible neurological injury and new postoperative deficits. It is able to identify critical brain regions and fiber bundles and to detect in an early stage a manipulation of neural structures. So the surgeon is informed and decides whether to proceed more carefully or to stop the surgery at this area at all. Different modalities of IOM are available, like EMG and EEG, but the evoked potentials are more relevant for the brain tumor surgeries, since they monitor specific neural pathways like the pyramidal pathway, the somatosensory, the visual pathways, or the auditory pathways, and the brainstem. The evoked potential technique involves applying a stimulus that generates a neuronal response, the electric potential. In case of SSEP, a peripheral nerve, for instance the median nerve at the wrist or the posterior tibial nerve at the ankle, is being stimulated. These potentials travel from the periphery to the brain and are recorded by electrodes placed over the scalp and along the transmission pathway. Motor evoked potentials are generated by transcranial electric stimulation using surface needle electrodes on the scalp or direct electrical stimulation on the brain cortex during the resection. Evoked potential are measured through peripheral electrodes placed in the muscle of interest, which is innervated from the eloquent brain region. Frequently used sites are thenar muscles, tibialis anterior, and abductor hallucis. Some of you may recognize here the typical electrophysiological curves. In case of manipulation of a critical structure during the surgery, we observe some changes in the curves, like this drop of the amplitude of the response compared to the baseline course. So we get the message either to proceed more carefully or to stop with the resection at this area. Without a doubt, the best method for neurological monitoring is the awake surgery. While the patient is awake, we stimulate the brain cortex, and depending on the patient's response, we identify the regions of the brain responsible for the speech and movements and protect this region during the surgery. In the next slide, we will watch some scenes during an awake surgery. At the beginning, we will perform the registration of the neonavigation. You may see the segmentation of the tumor marked in red, and in that way, we will be able to identify the borders of the tumor, which lies in deeper layers even before the beginning of resection. Then we will proceed with the brain mapping, and we'll talk to the patient and ask him to perform some speech tests or motor tests in order to identify the eloquent lesions. After performing the brain mapping, then we will proceed with the resection, and during the resection, the patients will be further asked to perform the speech and motor tests. We will now resume the principles of brain tumor surgery. Some decades ago, we observed carefully the MRIs, like this one. We identified anatomical landmarks like the hand notch and the precentral and postcentral gyrus, and speculated how much tumor resection was feasible. We were not able to identify critical motor fibers, whether the tumor infiltrated them or not. Consequently, most patients with such tumors have received only biopsies or had been speculatively resected. Nowadays, we identify the fibers before the surgery, so we plan our strategy accordingly. We monitor the neural pathways via evoked potentials, e.g., EMG, and further electrophysiological modules, but mainly via an awake surgery, which allows safe resections. And with the use of 5-alarm, interoperative ultrasound, and modern visualization techniques, we're able to maximize our resections. After this thorough description of the surgical routine, we will now bring up the current adjuvant therapies for patients with gliomas. Patients with gliomas WHO grade 2 to 4 undergo after surgery specific protocols of adjuvant therapies. The most common established modality of radiotherapy is the conventional fractionated focal brain radiation, which starts after the wound healing approximately 3 to 5 weeks after the surgery. In, in cases of multifocal glioblastomas, a whole brain radiotherapy may be considered, however, is usually avoided for safety reasons. The median dose of radiation is 50 to 60 grays at 1.8 to 2 grays per daily fraction over 6 weeks. In older patients with unfavorable prognostic factors like an unmethylated MGMT status or lower Karnofsky index, radiotherapy is administered in an hypofractionated manner with a median dose of about 40 grays over 3 weeks. Proton radiotherapy may be an option for younger patients, in particular those with low-grade gliomas and diffuse infiltration of eloquent areas in order to reduce brain toxicity. The role of stereotactic radiosurgery or re-radiation is not proven yet. The most common agent applied in patients with primary glioblastomas is temozolomide, an oral alkylating medicine which is usually well tolerated. This agent is more effective against patients with MGMT promoter methylation. Some other alkylating agents from the nitrosourea class, such as lomustine, carmustine, nimustine, or fortimustine, may also be a choice. Lomustine is often combined with procarbazine and vincristine in patients with grade 2 or 3 gliomas. Bevacizumab, a VEGF inhibitor, which prevents neovascularization, is usually used as a second-line treatment for recurrent glioblastomas. The STUP regimen appears as the standard of care treatment for primary glioblastomas and consists of a 6-week concomitant radiotherapy with fractionated focal radiation and temozolomide, followed by at least 6 cycles of adjuvant chemotherapy with temozolomide. This protocol has been established since the publication of Roger Stupp in New England Journal of Medicine in 2005, who found a superior overall survival in patients with primary glioblastomas after this protocol compared with radiotherapy alone. In 2020, Michael Weller, the successor of Roger Stupp at the University of Zurich, published the recommendations of EANO on management of gliomas in Nature reviews. We may see here the clinical pathway regarding the IDH mutant gliomas. In principle, patients with grade 2 or 3 oligodendrogliomas or astrocytomas with favorable prognostic factors, like after a complete tumor resection, may be initially only controlled or may receive chemoradiotherapy with PCV. The patients with unfavorable prognostic factors like incomplete resection, age over 40, or presence of neurological deficits do need an adjuvant chemoradiotherapy with PCV or temozolomide. Astrocytomas grade 4 will undergo radiotherapy followed by temozolomide without or with concomitant temozolomide. In case of patients with glioblastoma IDH wild type with unfavorable prognostic factors like Karnofsky score under 70, older age than 70, an unmethylated MGMT promoter, and hypofractionated radiotherapy alone may be considered. In cases of Karnofsky score under 50, we should proceed with the palliative care. In all other cases, the STUP regimen is applied. Electric fields allow a local treatment of the tumor. Tumor-treating fields are alternating electric fields transmitted via transducer arrays, which are applied to the scalp, as seen in the photo, and connected to a mobile device. Low intensity, at about 200 kHz fields, deform the mitotic spindle and promote apoptosis of cancer cells. These immunofluorescence images show clearly the disruption of the tubulin, marked in green, thus the cytoskeleton which inhibits mitosis. The combined treatment of temozolomide and tumor-treating pills prolonged significantly the overall survival in the EF-14 trial, and since then, tumor-treating pills are regarded as established treatment for primary glioblastomas. The role of immunotherapy in the treatment of gliomas has been investigated since many years with promising results. A phase 3 study conducted in 96 sites in 4 countries between 2007 and 2015 compared the outcome of patients after only standard of care treatment or after combined standard of care treatment and vaccination with autologous tumor-lysated-loaded dendritic cells, and found a statistic improved overall survival of 19.3 months after randomization against only 16.5. A similar phase 2 immunological study, which is launched by the University of Düsseldorf, compares the patient's outcome after only standard of care treatment or combined standard of care treatment with vaccination with autologous lysate-loaded mature dendritic cells. This study is still recruiting, but the interim analysis has shown a very promising results, and we are extremely happy that we participate in this study as department. Our first case is a 59 years old patient, Mr. K, who developed cognitive disorders and lethargy. The MRI depicted a ventricular tumor without contrast, enhancement, and hydrocephalus, so we expect rather a low-grade glioma in this region. The next slide will show you some scenes from the operation. As we may see in the pre- and postoperative MRIs, the tumor has been completely resected. The patient recovered well without any neurological deficits. The histology confirmed an ependymoma WHO grade 1. So we have here the case of a complete resection and benign glioma grade 1. So no further adjuvant therapy is needed. The next case is Mr. P, 57 years old, with brainstem symptoms and deficits of the cranial nerves 7 and 8. You may observe a tumor in the cerebellopontine angle. This has been resected. This patient recovered also from his symptoms. The histology showed an myxopapillary ependymoma grade 1, MIB until 1%. So same case, benign tumor, no adjuvant therapy is indicated. The third case, Mr. J, 49 years old, developed brainstem symptoms and deficits of the caudal cranial nerves. We may see in the MRI a tumor on the apex of the fourth ventricle, also without contrast enhancement, so we expect also low-grade glioma. We may see here the complete resection of the tumor. Patients improved neurologically. The histology showed a subependymoma WHO grade 2. In this case, we should exclude that no other tumor manifestations are cranially or on the spinal cord. We performed the relevant MRI scans, and we excluded some other tumor manifestations. So after a complete resection and without any other tumor manifestations, no further adjuvant therapy is needed. The fourth case, a young patient, Mr. H, 35 years old, with spinal cord syndrome, motor and sensible deficits, developed a huge intramedullary tumor in the cervical and thoracal spine. You may see the operation at the next slide. So the histology showed an ependymoma WHO grade 2. The tumor has been completely resected as seen in this MRIs. Similarly to the previous case, we excluded any other tumor manifestations in the spinal cord or cranially, and we proceeded with the conservative therapy. No adjuvant therapy is indicated in this case. The fifth case, Mr. K, 61 years old, developed also cognitive disorders and lethargy. This MRI showed an interventricular tumor, but with contrast enhancement this time. So we expect rather a high-grade tumor. We proceeded with the surgery and performed an endoscopically resection of the tumor. You may see here the prolapse of the septum pellucidity. It corresponds to this wall of the tumor, and at the lower picture you may see the first stages of resection. You may see here the complete resection without any tumor remnants. And the MRI confirms the complete resection. Patients had no neurological deficits after the surgery. However, he had a high-grade astrocytoma grade 3 ADH1 mutant. So we indicated an adjuvant therapy with 60-grade radiation and temozolomide. The sixth case is Mrs. R, 61 years old, also cognitive disorders, but also seizures, and showed a diffuse tumor at the right temporal lobe and in the insula. We operated, but left a small tumor remnant at the insula. Patients had no neurological deficits and no epilepsy after the surgery. The histology showed grade 3 astrocytoma, ADH1 mutant. So we proceeded with adjuvant therapy with 60-grade radiation and temozolomide. Next case, Mr. D, 61 years old, developed motor and sensoric aphasia, hemiparesis, and seizures. The MRI showed a tumor at the left temporal lobe, gyrus angularis in the insula, and language region. We performed an awake surgery, and we were able to resect completely the tumor. Postoperative, the language deficits improved. The histology showed an glioblastoma, WHO grade 4, IDH1 wild type in GMT methylated, so he received the Stupp regimen. This case is a similar case, also motor and sensoric aphasia and mild hemiparesis at the right side. The MRI showed a tumor at the left frontal operculum, gyrus angularis, and language region. We performed also an awake surgery, but we were not able to resect completely the tumor. As you may see here, we have left a tumor remnant at the frontal operculum as he developed language deficits during the surgery, or his known language deficits have been deteriorating during the surgery. So we left a small remnant. However, postoperative the language deficits have been improved. The histology is shown in glioblastoma grade 4. we indicated the adjuvant therapy with stoop regimen and tumor treating phase. I'll show you now a case of an older lady, Mrs. J, 80 years old, with visual deficits and cognitive disorders. I would like to demonstrate that not every tumor is resectable. This tumor has been localized in the splenium, so under consideration of the localization of the tumor and the age of the patient, we proceeded with stereotactic biopsy, confirmed the glioblastoma grade 4, and indicated the adjuvant therapy, fractionated radiation, and temozolomide, but not further resection. And our last case is a lady 67 years old with motor and sensoric aphasia and mild hemiparesis, apparently due to the edema. Showed a tumor frontal close to corpus callosum left. The tumor has been completely resected. The patient has had no neurological deficits after the surgery. The histology showed a glioblastoma grade 4, IDH1 wild type, MGMT methylated. We indicated a stoop regimen, but also recruited the patient into the Gliovax study. So this patient receives also her own vaccines against her own tumor. So thank you very much for your attention, and I wish you a successful training.
Yeah, that's the end of the talk. And we actually noticed that there were some issues with the recording that we couldn't handle at our own end. But I'll try to rectify these issues, and I'm going to drop the link in the YouTube channel so that you can as well look into this talk if you want to have more details about it later on. Yes, the sound issues I can see in the chat is not from our end, it's from the recording that we received. Okay, yeah, so this brings us to the end of the PM seminar for today. It's quite unfortunate that we had a bad recording, but as I said earlier on, I'll try to fix the sound and we'll leave it on the YouTube channel for us to access. Going forward today, some of us will be going for our code sessions, team exercises, and various tasks for the rest of the day. I would like to close it here today, and in the absence of any questions, we'll head over to our various teams. But if you have any questions for Dr. Constantinos Garcias from this talk, please, you should send it to spark@mylab.io, which has been our contact email. Yeah, I think that's it for now. Thank you so much for this time. Sorry for the bad recording we had. I'll try to fix that and make a better sound available for us. Thank you so much. We'll see you at the Omonja session, which will be happening in about 2 hours from now. And with that, we'll have this session closed, and we'll see you all later then. Thank you.
Thank you.